Welcome to Access Amplified, the podcast where we shine a light on how digital health is increasing access to care and advancing equity around the world. I'm your host, Joanna Brownold, and our podcast is brought to you by Taito Care. And in each episode, we're going to sit down with healthcare leaders who are doing the work, not just reimagining access, but actually rebuilding it from the ground up. Today, I'm joined by Sam McGinnis, Administrative Director at Atrium Health Levine Children. Thank you so much for joining us today, Sam.
Absolutely. Happy to be on.
Sam leads one of the largest and most impactful school-based virtual care programs in the country. He serves over 150 schools across 2 states, and his team has found a way to meet children and families on campus where they are already supporting overburdened school nurses and expanding access far beyond the traditional clinic walls. We're going to talk about how that program works, how it's scalable, pediatric access, and how school health can impact that. So let's get started. Sam, let's start at the beginning. What really sparked the idea to bring virtual care into schools? And then how did that program evolve from a pilot to this now huge program that you have 260 schools across 2 states?
All right. So interestingly, our first school, which was Graham Elementary, located in Cleveland County, of which I'm a native, actually reached out to us saying that they needed some help. They were struggling with chronic absenteeism, and we developed a pilot where we wanted to have a telepresenter actually go out to the school to assist the school nurses, right, and to provide evaluation and treatment. Once we started the pilot, we pretty quickly realized that we have a pretty unique opportunity to reach a population that historically has had a lot of challenges accessing care within our clinic walls. So when we looked at that pilot, we actually studied some outcomes from that 2017 pilot and found that 90% of our students were able to stay in school. 20% of those students 20% of those students actually had no primary care medical home. And at the time, there's a clinic called Shelby Children's Clinic that exists in Cleveland County that takes care of the vast majority of students in Cleveland County. And so to find out that 20% of the students were not coming to one of our clinics and in all likelihood using the emergency department for any sort of primary care services was really pretty shocking to us, right? We also noticed in that pilot that there was a 55% reduction in emergency department utilization by that cohort of students. And so realizing that we can really have a tremendous impact on where we're sending patients and really how they're accessing care. So when we looked at those initial results, it really got us thinking about how we can continue to grow and study the model a little bit more. And so now, looking at the numbers that you shared, we've actually completed over 50,000 visits for almost 27,000 students, right? And so that even includes the COVID-19 protocols, right? So a couple of years where students were dismissed. We've seen still nearly 60% of our patients, including staff members, stay at school. And so it really is pretty incredible.
Absolutely. And you mentioned that there are some care access challenges in your area. Can you just kind of share a little bit more about what those look like and how they impact the families that you're serving?
Yeah, I mean, I think oftentimes families struggle to find time to get away from work or to have the ability to get into a doctor's office that generally is very busy, within the time frame that they need to get the child back to school. So we know what happens in the midst of sick season is oftentimes in our home county, we run out of appointments pretty early in the day. And so we really wanted to rethink the way in which we create access, right? And hopefully doing that within the walls of the school, ideally keeping the child healthy and in school and learning if they're not contagious. But if they are contagious, at least they're leaving school with a diagnosis and a treatment plan, and hopefully returning to school much, much quicker than they would if they had to go home, call the doctor's office, wait till the day or the day after to get an appointment.
Right, because they're losing time like that with all of that kind of first go home and then solve, whereas now you're kind of saying we're going to solve those challenges, or we're going to at least diagnose those problems now, and then at least you know what the next steps are. And there was another question that I wanted to ask, because you mentioned, especially in the pilot already, you had kind of sent a telepresenter to the school. Why did you choose that model as opposed to relying on school nurses? And then how do you scale that? Because obviously you're in so many schools now, that's a lot of extra manpower that you're going to need there.
Yeah. Really good question. And I think it really goes back to realizing early on that we saw that school nurses have an overwhelming job.
Hmm.
While school nurses would love to help provide care when it's needed, they don't have the capacity or the time to do so. Oftentimes, there's a line of students waiting to have the school nurse look at them and figure out what they need to do, right? You add that with medication administration, you add that with education, you add that with all these other functions that school nurses have to do. We needed to design a model to support school nurses by having teammates available or resources available to respond to the needs of the school and really serve as the hands of a clinician, but at the same time allowing school nurses to focus on other tasks while the visit takes place, right? And so not only does that help free up the school nurse to continue to be a school nurse, but it also allows us to expand our clinician covered capabilities as well, right? So instead of having a clinician trying to travel from school to school, we now have all of these telepresenters that are out serving as the hands of the clinician and allowing them to jump from one visit to another to keep them in productive.
Hmm. And what defines a telepresenter? How do you train them? What skills do they have? What training do they have? And what qualifications do they have? And then is that one per school? Like, are they based there? I have lots of questions about the telepresenters. Are they based there all the time?
So it depends on the school and how much utilization exists at that school, right? So a
Mhm.
telepresenter is typically a certified or a registered medical assistant. They undergo special training on how to operate digital diagnostic equipment. They also understand all components of a normal office visit that would exist in a brick and mortar setting, and then also how to perform an examination at the direction of a clinician. Once we feel that they're comfortable with that training and understand the role within being a mobile healthcare teammate, we then assign them either one school or a subset of schools that are geographically located in close proximity to each other. And then what we try to do is make sure that we have a target number of visits that telepresenters can achieve per day, right? And so our goal in doing that is to make sure not only are we not keeping schools and school nurses waiting very long, but also making sure that we're being good stewards of our telepresenter resources and allowing them to uh, maximize, the limited amount of time that they have in the day with providing care.
And so some of them are traveling around, some of them are kind of staying where they are. And really, so what I'm kind of understanding is they're the hands of the clinician who's remote. Where is the clinician based?
Yeah, so the clinician is generally located either at home or in an office. And then what they can do is they can cover many different schools within the district. They can also
Mhm.
cover districts. Some of our clinicians are licensed across North Carolina and Georgia and can cover two states. And so when you look at the scale of a clinician and being able to serve students, it creates quite amazing capacity for them to be able to care for many different schools and many different students during a single day.
Right. So we're kind of stretching that very limited resource. Okay. And then in terms of the school nurses, obviously we know that, school nurses are incredibly limited because there are major staffing shortages. You kind of spoke a little bit already about how your telepresenters are supporting them. And I know that in the past, we've spoken, you've emphasized that school nurses are really essential. What is the goal of this program? Is it eventually, it's not to replace school nurses, right?
Yeah, it's a good question, right? And I think that what we quickly realize is that fundamentally, we know that school nursing serves as an integral part of student health, right? There's many tasks that require a school nurse to be on site at the school, physically performing nursing functions, right? And we can't replace many of those functions with virtual coverage. What we can do is really leverage our ability to support school nurses in areas where, number one, we could potentially use virtual technology to expand our reach, expand our capabilities. We can also help school nurses by connecting students or staff with care once the school nurse identifies that that's a need, right? And so while many districts will continue to face challenges with school nursing coverage, right, and this is natural trends, they seem to indicate that this problem is going to continue. as official healthcare partners with our districts, now is a very important time for us to start reimagining what school nursing is, what it needs to look like, how are we going to meet the headwinds that are presenting themselves today, as well as potential future headwinds, whether those are financial, whether those are staffing shortages. There's a number of different scenarios where the time is right for us to start thinking about how we can design models to support and preserve in-person school nursing while leveraging technology to expand the capability.
Right. I really like that idea. So, I mean, school nurses need to stay, they're not going anywhere, but how can we make their lives easier? And you also kind of mentioned something that was interesting. You said that the school nurses can kind of then identify where a patient might need, or where a child might not have care and might then need to be enrolled in care. Maybe it's like, an ongoing chronic issue. Is that something that you work directly with the nurses at, or is that kind of a telepresenter job? How does that fit in?
Yeah, so if we identify the need for chronic condition management, follow-up care that needs brick and mortar services, right? We help to coordinate that with either the primary care physician of that patient, if they have one, and perhaps more importantly, if they don't have one, we can establish them with a primary care medical home. And that's really the beauty of a partnership with a healthcare system that has pediatric practices located in the area, is that we are working for families that don't have a primary care medical home to help establish them. And it may be a really unique opportunity for us to educate the parents about the value and the importance of a primary care medical home and the importance of well child care, right? And so we really value the opportunity when we have an opportunity to see a child that perhaps we haven't engaged with before, to let the parents know what we can do from within the schools, but also what we can do to help coordinate care within a brick and mortar practice, or even with virtual primary care, which are some new capabilities that we have coming down the pipeline.
Mhm. And I think, you've spoken about this with us before, about how you're working really hard to meet families within their rhythm of their lives, which I think is kind of where this falls into. So how do you take care beyond those school walls? So you've kind of spoken about connecting patients who need with a primary care provider. How can you make that more accessible as well? In the evenings, the weekends, from home, whatever that looks like. Because I know that that's something that you're also working on.
Yeah, that's a really good question, and it's something we've been challenging ourselves to think more broadly about, right? And so, doing a lot of thinking around how do we extend care both in person to include nights and weekends, leveraging our extended care clinics, but also with virtual primary care. Think about the tremendous opportunity that we have to reach families, after work, right? If they have questions, concerns, issues, problems, where they don't even need to be within the walls of the schools if they have internet connectivity, right? How do we help expand our services and make sure that we can be a layer of continuity within the patient's medical home, right? So often, let's say if a patient is established at a pediatric practice that exists, Monday through Friday, and they're open 8 a.m. to 5 p.m., concerns come up after hours, right? And so, how do we help create another layer of continuity to be able to be there to answer questions, hopefully diagnose and treat any concerns, but also getting that information back to their primary care physician for them to coordinate and help continue ongoing management. And that's a lot of the work that we're doing right now, specifically around some of the virtual primary care initiatives that we have, right? There's incredible opportunity with virtual primary care to do a lot of things virtually. We still need in-person components of well child care. We still need immunizations. We still need lab work. But we can do a lot of things to help a lot of families if we really think outside the box and how we design the system to be able to create a relationship-based primary care model.
And are you finding that to be successful? And I mean, how do we define success? Obviously. And in this case, I'm going to say success is defined as a child getting ongoing care, which might not necessarily be the health system's definition of success, but for the purposes of this conversation, are you seeing that they're staying engaged? Are you seeing that they're then leveraging that, advocate, and Atrium as a resource?
Yeah, it's a new initiative and it's something that we're really closely tracking. We've seen a lot of uptick in interest in this model, which is encouraging, right? Is that we want to make sure that we make getting healthcare simple, right? And I feel like a lot of times it can be a challenge for a lot of families to navigate complex healthcare system, right? So let's create easy options to meet with a clinician. Another major opportunity is in North Carolina, we have 100 counties, right? 19 of those counties don't have a pediatrician. If we can look at ways to leverage providing a majority of virtual primary care for these areas, that's a pretty substantial change to what they have available to them at the moment, right? Providing
Absolutely.
you can do, let's say, 80% of care virtually and only have to travel to a doctor's office to have truly services that need brick and mortar, diagnosis and treatment or services that need to happen in a doctor's office. That's pretty substantial for those families to now have access to pediatric care. And I think that that's really the vision that I love about this work is that we are serving areas in a way in which we have never done before. And the answer for them not to have access to this sort of care is unacceptable.
Absolutely. Just kind of going back to some of the more technical elements of it. Are the clinicians who are serving the hospitals the same clinicians? Like, is it the same pool of clinicians who are then serving the virtual primary care requests as well?
Yeah, so the short answer is it can be. We actually have a dedicated school-based team that is a part of our Levine Children's virtual umbrella, so to say. So that includes not only our school-based team, we also have what's called our pediatric urgent care video visit team. So we do pediatric video visits currently from 7 a.m. to 11 p.m., soon to launch 24 hours a day. And then we have virtual primary care, which is really more relationship-based primary care, right? And so we look at ourselves not only as an extension of your normal primary care physician's office, if you have that, but also the ability to establish with a virtual primary care physician where we can do the vast majority of your care virtually and then subsequently coordinate in-person services at one of our
Where
practices.
needed. Okay. And the urgent care, this is basically a telephone, this is a video urgent care service? Because we haven't spoken about that before, and that's really interesting to me.
Yeah, so it is. It's two-way video conferencing, right? So we see very strong utilization, typically about 5 o'clock p.m. when the clinics start closing into the evening, right? And on weekends, it's an option for families to do a two-way video visit for common acute conditions that present. So we see a lot of that, especially in the midst of sick season, that really help to create more accessibility for the families where they don't even have to leave home, understanding that those sorts of two-way video conferencing visits really don't have the capabilities that exist with your technology of being able to look into the ear, listen to the heart and lungs, etc. So we're a little bit more limited in the conditions we can diagnose and treat, but we have other models of care, including school-based virtual care and hopefully some equipment with virtual primary care that will allow us to really expand our scope.
Okay. I mean, obviously, our kids don't get sick on schedule, right? I mean, that would be really nice if they got sick when we were
Absolutely.
at or near a doctor's office whilst the doctor's office was open. But that has never once happened to my kids. It's always 10:30 at night start screaming. So actually, that kind of 24/7 um, urgent care call in is invaluable, I would say. Let's go back to the schools for a minute because you serve schools that are across a lot of different districts and they're also across a lot of different kind of settings. So you've got urban, rural, and kind of everything in between. What have you learned from serving such a variety of settings geographically? Are there common themes that run through those challenges?
Yeah, so good question. And I think that probably the biggest lesson is that we need to listen to the schools and the school nurses and understand that no two schools are ever exactly the same, right? I think in every district that I've ever had the pleasure of meeting with, initially asked, hey, can you serve faculty and staff, right? And so I found that to be very interesting. And then we quickly learned that we need to add a faculty and staff component, right, in partnership with our family medicine colleagues. I think also what's really important is making sure that we understand the school district's challenges before we come in saying what we can and can't do. Before we recommend a solution, we need to make sure that we have some flexibility or maintain flexibility to really adapt to the unique needs of those districts really and make the most of the opportunities that we have to grow our program or evolve our program when challenges or problems really present. themselves, right? And so I think not only that, but also staying relevant to national trends, like funding decisions at the national level, at the state level, at the local level. All of these have impacts on how school districts are operating, school health resources. And so making sure that we understand what potentially is coming down the pipeline and making sure that we are helping plan in partnership with the districts of how we can meet the challenges together.
And I wanted to actually talk to you about kind of policies and funding shifts because obviously that's impacting schools across the country, it's impacting health systems across the country, and you're really at the junction of those two. What could policies or funding shifts help models like yours to grow? And like, where do you see challenges with that? Where do you see things getting in the way?
Yeah, I think that what we have to do is continue to work together to demonstrate outcomes, right? Is that we need to show the value in the work that we're doing. And I think that payers and legislators will take notice of the work that we're doing and hopefully kind of create an evolution of how we're reimbursed for some of the services that we do, right? We know that a telepresenter is an extra resource in providing virtual care, right? But it's a needed resource, right? So I think recognizing that there are unique virtual care models that exist and also making sure that we have the adequate reimbursement for the services with our payers to continue to do this sort of work, right? We know that there's value and there's opportunity in virtual care. We know that with the assistance of a mobilized workforce, there's a tremendous amount of opportunity out there to reach families, reach students, and in places that we have traditionally struggled or not been able to reach these families. And so I think making sure that we understand the work that we're doing, the impact of the work that we're doing, and then collectively advocating together with others that are doing similar work to say, hey, you guys need to recognize the value of the sorts of pilots that we're doing out here. Look at the return on investment of reduction in emergency department visits, reduction in hospitalizations, reduction in missed time from work, reduction in gas expense. All of these things are helping families and really creating healthier opportunities for our patients. And think that we're doing a lot of good work. I've had the pleasure of working with Dr. John Jenkins, who I believe has been on your program as well, and really trying to collectively come together as a part of school health collaborative works throughout the Carolinas to really call attention to the work that we're doing and making sure that we're tracking things consistently and helping to jointly advocate for each other in our collective successes.
Yeah, I was going to say, I know that you have the North Carolina Collaborative School. Remind me the name?
North Carolina or the Carolina School-Based Health Collaborative.
There we go. And I love the idea of, typically potentially competing health systems. I don't want to like actually pit you guys against each other, but I love the idea of pooling resources, pooling ideas, and pooling power as well, right? As you lobby, as you share ideas, as you speak with people who are making decisions in terms of funding, and I think that's also something that people from across the country could kind of take and learn from about how there's really a group of health systems working towards school care together. I think that's really powerful. I did have a question about, you said that you also serve staff and teachers. Yeah, a lot of the school systems that we work with are kind of just primarily focused on the students. First of all, why did you want to also make sure that you included the staff and the teachers? And secondly, how does that work? And, we're just speaking about how the payments work and working with the insurers. Does that add a level of complexity to the program?
Yes, I think number one, I think that, as I mentioned, every district and probably every school that we've met with that said, this is great. I need it for my faculty and staff. They
Okay.
oftentimes come to school sicker than the students. And it
Yeah.
is true, right? They also present with uh, concerns that are unique to adult population, right? And so they have different problems that they're coming to us with. And because when you think about it, like let's just say that teacher's out for 2 or 3 days. Think about the impact of that, right? That's a major impact for education in and of itself.
Hmm.
Uh, we, uh, we know that when a substitute teacher is in the school, they may not be fully equipped to keep a lesson plan on track, assess student progress, communicate with parents, all these things, right? And so when one teacher's out, that's sometimes 30, 45 students that are impacted, right? Their learning is impacted by that absence. And so it's critical to keep not only students, but faculty and staff in schools as well. Now, I would say that the feedback that we've received suggests that the faculty and staff component really helps support districts with over half of our faculty and staff being able to stay at school and continue teaching, right? And so I would say that it's been very good work. Now, to the second part of your question, we don't see a tremendous impact in payer coverage.
Okay, that's great. I think that's really important. My mum's a teacher, and I think I can count that, she's just retired. So she's been teaching for that long. And I think I can count on one hand the number of sick days she's taken over the years. And she loses her voice at least once a year. So having this kind of, and she goes into school and she's like teaching this class and she can't talk. So the impact of having care where you work, whether that is a school or whether it's a work site, is so impactful. I want to start to wrap up, but I've got a more personal question for you to finish up. You've been with Atrium for over 15 years now. What keeps you inspired, and what are you most proud of in the work that you're doing now?
It's a good question. I think first and foremost, I love the work that I do. I am, personally aligned with the mission and the vision of the organization. I think, at Advocate Health, we're given permission to think boldly. We're not afraid to try new things. We're not afraid to push the status quo. We're not afraid to look at an environment such as healthcare that sometimes is reluctant to want to try new things and have a lot of, operating innovation, so to say. I think that we do a lot of that, right? I also love being a part of a program and a system that really allows us to lead the way. And I think that this work in particular is a really great example of how we live out our organizational commitments, really to lift everyone up, to provide care for all. That's what we're doing, right? And so it's nice being able to work with a program and help be a part of the leadership team of a program that really just is out to provide care for all. And I think that's a special thing. And I don't think that exists uniformly across many areas of healthcare. And so I'm proud to be a part of that, and I'm proud to help know that I'm a small part of the program's success and continued evolution.
I would say big part, but I thank you for sharing that. I think the work that you're doing is so impactful, and I think coming to work every day knowing and seeing the impact that you're having is amazing. Thank you so much for joining me today. It was a pleasure chatting with you.
Thank you so much for having me. I really enjoyed it.
Great. If you enjoyed today's conversation, please be sure to follow or subscribe wherever you get your podcasts. New episodes drop every 2 weeks. Please share this episode with a colleague who's passionate about digital health, access, or rethinking care delivery. Access Amplified is brought to you by Taito Care. I'm Joanna Brownold. Thank you so much for listening, and we'll see you next time.